Diabetic Feet. She is also a founding member of the Diabetic Foot Working Group in Slovenia, and she is a member of the Diabetic Foot Study Group. Welcome Dr. Shara for her talk on the surgical management of diabetic foot. I worked in a few centers across a few of the parts of the world and visited a few parts, but I've never expected an orthopedic surgeon to be interested in a diabetic foot. I've never seen one, and that too a female surgeon. Let's see what she has to tell us. Thank you.
Thank you for this most kind introduction. Now I hope I find a slideshow. That would be helpful. Okay, it works. I don't know where to start actually, because Andrew opened many issues, like the white coats. Are you wearing white coats in India?
Yes.
Well, we do in Slovenia, but I have to say we wash them properly every day. So maybe that's the reason why you have so much infection with white coats. Second one is, of course, the surgical part, like larvae. But I will come to that issue a little bit later. First of all, I would like to show you where my country, Slovenia, is. It is to all of you familiar where Austria and Italy are, I'm sure. And this tiny little piece here in the middle of Europe on the edge of Mediterranean is my country, Ljubljana, the capital, in the middle. And this is the mountain part of Bled with a nice castle and a lake. And this is my hometown, Ljubljana. And also we have a tiny little piece of Mediterranean. So pleasant slides for the start and slightly less pleasant slides to continue. So larvae in Manchester refused to treat these two patients. And that is why Andrew sent them to me. What is she going to do? As a regular classical surgeon, she's going, amputation, isn't it the best solution? It offers fast recovery, and isn't it better to walk with prosthesis? They all go to the rehab centers and they come out healed completely. This may well be true, but not for a diabetic patient. Why? Because in 2 to 3 years, after the first side is amputated, the second one follows. And even worse, mortality rate in diabetic patients connected to diabetic foot ulcer or Charcot is extremely high. This is why surgeons began to think about a surgical approach and developed a few approaches, like a curative one, where we treat infection and try to improve blood supply. And we have elective methods like plastic surgery, orthopedic surgical methods, and one of them also being preventative. I'm going to talk about neuropathic foot ulcer. A classic neuropathic foot ulcer is in a severely deformed foot, usually under metatarsal heads. You can see a lot of callus around it, and the skin itself is warm and there is no blood supply impairment. So this is the wound I can heal. I usually start with using knives for our debridement. We take a lot of all the necrotic tissue away, and then we put an appropriate dressing and plaster cast the patient. We use plaster casts, not very, very rarely removable devices, because patients tend to be non-compliant. And it does work. I can show you in a few slides. This is a pair of feet of one of my patients. Only after the first visit and a few visits after, and in about 10 to 12 weeks, both feet are healed with the same approach. But sometimes it does not work that easy. Marco is a 52 years old patient of mine, diabetic, who has been carrying around his wound for more than a year. We started with our approach, offloading, debridement, and it worked well. We healed Marco basically in a few weeks, but we were faced with ulcer recurrence. He was working, he was fitted in custom-made shoes, but he had to spend most of the time walking while, because his job demanded that. So I found a tiny little deformity of the third metatarsal. I performed an osteotomy, which made it a little bit shorter. I used no fixation for that. And here is Marco, 2 years after surgery, with his foot nicely healed and ulcer-free. Today, on the other hand, has a severe deformity after infection 3 years ago, and now he cannot fit into any shoe because he's got a completely vertical first toe compared to the rest. So whenever fitted in a shoe, he's got a problem, and under a metatarsal head, you can clearly see a wound which would not heal. And this is a nice X-ray of him. You are a reconstructive surgeon, so please keep my first toe. So my colleagues were laughing at me, and it hasn't been easy. And also, my first attempt hasn't been complete because I was faced with only remnants of bone. But when I shortened the soft tissues and used the little bone left, fixed with only Kirschner wire, I succeeded, and today is healed and fitted in custom-made shoes, still regularly visiting my outpatient with a tiny little hyperkeratosis on the plantar side. So neuropathic foot ulcers would heal if we take the pressure away. But also, on the other hand, ulcer recurrence is extremely frequent in these patients. So whenever you fail with a classic offloading, think of including a surgeon for a surgical offloading and correction of deformities. If you remember the first slide, and Andrew's patient, Mattea, who is blind, lives alone with a huge neuropathic foot ulcer, she refuses offloading. Various other methods have been tried and tested, but unfortunately not successful. So after another severe infection, I decided to do a little bit of a sacrifice, and I took the bony part, some of it with osteomyelitis, and I made a fillet flap, sutured it into the defect, and this was Mattea, nicely healed 3 to 4 weeks after the surgery. So other possibilities are here in order to heal diabetic feet. Peter, 42 years old, another ulcer. Would you take a wound swab? Would you treat him with antibiotics? No, because he hasn't got any clinical signs. And the main message I wish to share with you is that every non-healing wound presents a threat for infection and inflammation, which very easily leads to amputation. Infection is spreading fast in diabetics. They are at great risk for both necrotizing cellulitis or necrotizing fasciitis, which looks even more serious and dangerous. This is why we have to take serious every wound. Stane, 62 years old patient of mine with a severe deformity, probe to bone test positive, was offloaded, but not only offloaded, I removed the osteomyelitic part of the bone, added antibiotics, and he is nicely healed ever since. So try to revert and change infection from into a non-infected wound and succeed with healing. Can surgery prevent ulcer development? Yes, of course. Very simple methods: arthroplasty, arthrodesis, hallux valgus correction. If you do it fast enough, you can prevent serious infection in your patient. So yes, there is a place for preventative surgery. Vasya is a relatively young patient of mine, still working and presenting with a red hot swollen foot. You guessed, it is Charcot. And every red hot swollen foot should be considered as a Charcot in a diabetic patient until proven otherwise. You can hear very often that Charcot is a rare disease, and again, this is not true for diabetics. It is very, very common, and I remember my outpatient clinic 10 years ago, I treated 1 or 2 Charcots maybe, while now I'm treating constantly 5 to 10 acute Charcots in my tiny little Slovenia, 1.8 million people, for those of you who do not know. So there is a lot of Charcot. One only has to look for it. You are familiar with all these stages of acute, where you have a swelling, warmth, and destruction, and then finally everything heals up in a severely deformed foot. So would you distinguish between these 2 X-rays? Which one is which? There are a few sentences to help you. If there is no ulcer, it almost certainly is Charcot. If there is ulcer and Charcot, and help yourself with imaging, hopefully you have some better X-ray technicians than I have, because sometimes I receive quite weird answers. So the best imaging technique I would use is scan with labeled white blood cells if I'm puzzled. And if those 2 were easy, this is another patient of mine where we are not sure whether we're speaking about Charcot or infection. And a patient of mine who called me from a peripheral hospital in Slovenia, he said, well, Dr. Shara, a surgeon decided my foot is infected and needs below-knee amputation. I do not agree with the procedure. Could you see me? Could I visit you in your outpatient clinic? His CRP values were high. He had fever also. He was on antibiotics already when I received him in my department. And here is his foot. Huge swelling of the foot and ankle. To begin with, I was not sure, but when making the scan, it was proven that this was Charcot, with a tiny little bit of osteomyelitis here, which was surgically debrided, and after plaster casting, he is still doing well with both his feet. So we have a lot of problems with Charcot because we misdiagnose a lot of them. For infection, osteomyelitis, for DVT, lymphedema, fracture, arthrosis, and even tumor. Okay, we all make mistakes, but the worst thing is that we advise the patient to walk as much as possible in many of these diagnoses. And on the contrary, patient should be immobilized and resting, having Charcot. So if we move to treatment, we can have medical, offloading, or surgery in acute Charcot. Clearly you can see that the line is much longer for a physician than a surgeon. But despite this, do we have any drugs we can rely on, like bisphosphonates or calcitonin or even other hormones. At the moment, we haven't got them. So we still have to stick to our friend surgeons who are going to prescribe crutches or even better, total contact cast, rest, or other devices, air casts. Everything is popular, but everything is worse. The best is a total contact cast, because all the other devices patients tend to take away because they have to wear them for a very long period of time. And if we move to a chronic disease, we can have minor changes of anatomy, we can have deformity, or even worse, we can have joint instability, which can cause wound. Forefoot is the easiest to treat, and every diabetes specialist can send and refer a patient with a tiny little deformity to a shoe fitter. While these changes in the midfoot, where we can observe the rocker bottom deformity, and more than 60% of foot wounds are present in this part. So this is a more complicated part of the foot. Very often, shoes will not be enough. Stoyan, a 73 years old patient of mine, was lucky. He developed his deformity on the lateral part or medial part of the foot, not the rocker bottom deformity. But still, whenever fitted in a shoe, small ulcer opened, and his wound got inflamed, and this is why I decided to remove the exostotic bone, suture the defect, and Stoyan was fitted in almost regular shoe afterwards. The worst deformity is the ankle joint deformity. This is where custom-made footwear would fail, and it's very difficult to find a suitable orthosis for a patient, and you can imagine that this one is not going to fit into anything. Can we offer surgery to these patients? Maria, a 74 years old patient of mine, where Charcot has never been recognized or treated, came to my outpatient with severe instability and osteomyelitis of the lateral malleolus with constant opened wound. Maria, this is her foot. Before I started surgery, one can twist it around. It's all soft and unstable. I used the retrograde nailing system, and Maria, a few days after surgery, stands already with support, and a few years later,